participating in the class, and you'll have interaction with the mentor, with the teacher, where you can actually get your doubts solved and all those things. Then we have recorded classes where you can access the subjects. So it is like, anywhere, anytime. So you have the classes at your fingertips. And we have notes. So it is an ultimate comprehensive books, which is based on CBME. And the MCQs are there. And also to have a fun part in it, we have the fun zone where you can have fun learning anatomy for self-assessment. And we have a set of MCQs. So the MCQs range from beginner level up to the expert level. That means you can start at a basic level with a few fundamentals. And as you gain the confidence, you can go to higher levels and assess yourself. So there are standard multiple choice questions, which you can see them in your CBME question papers, as well as in the NEET exams, which later on helps you prepare for your postgraduate entrance exams. So here we offer to you subscription plans. So we have 3 plans: basic for 3 months, standard for 6 months, and mentorship for 12 months. So I would like to talk a little bit about the mentorship program, since it is a long-term program. So here we offer you pre-recorded classes, live classes. You can access the pre-recorded classes as well, anytime. And you have a live doubt clarification, which is like a bonus here. Like, you can ask in the live class. And you have one-to-one personalized guidance. So you will be offered counseling and guidance as to whatever issues you would have. And we also give you the notes, and there will also be a quick revision examination module. And all these things comes at actually, the package is about 62,500, but we offer you at a special price of 50,000. And if you use the code DRDI, which is given down here, DRDIVYA 20, we offer 20% discount over. So you can book a slot for personalized counseling session, and this is available through the website or through the Auricle app. And in this internal the internal exam marathon, what we are starting today. So this is for about 45 days duration. So here we are basically focusing on all the important questions which are asked in the exams and how to answer them for a better scoring and for a better presentation in the exam. So as to, it's like a rapid revision. And certain facts, especially in anatomy, it is very volatile. I think somebody...
It's some bread packet.
Jayendra, can you mute yourself? Like we can hear you. Yes. So there will be, usually anatomy is kind of considered as volatile. So that is why students are very apprehensive about anatomy. But then here we will give you some facts and quick revision where it will help you. And then multiple choice questions will be covered. We assure top-notch grade. So with all these things, we prepare you for the exams, and where you will be able to score better. So this is beneficial for all the state exams. You may have a doubt whether it is whether the portions of different universities are covered or not. But here, since it is the common syllabus and the common type of examination we have, so we will cover all the state syllabus here. Means basically the type of questions which are asked in different state syllabus patterns. So with this, we start with today's class. That is the first marathon series by head and neck. So here the objectives of today's class is we will be focusing on the long and short essays which are commonly asked and short answers. So today's topic, we will be talking about scalp, the dangerous area of the scalp, then facial artery and vein, the facial nerve, and lacrimal apparatus. And short answers will be focusing on the orbicularis oculi, orbicularis oris, buccinator, the venous drainage of face, and sensory innervation of the face. So first coming to the essays. So here we'll go by one. So first is scalp and dangerous area of the scalp. So usually this is a very common question which is asked in the exam, and you need to know. So it is like, the exam is for 3 hours duration. So always the problem with students is lack of time. They always complain like we knew the answers, but we couldn't write and finish it within the given slot of time. So that is the thing. And they will be like, we wrote so much, but still we couldn't score. So these two are the issues. So the thing is how to present the answer. So it is like answering smart, which is important, and the core points, which is, it's like, textbooks are very vast. So you can't remember each and every word which is given in the textbook. But there are certain things which you need to remember, which is very essential. So those things you need to focus on, and those things are the ones which an examiner will be looking for in an answer. So you need to focus on such points, and these are the things which we will be doing here in the classes. So first, coming to the question scalp. So when scalp question is asked, so scalp question is asked under various headings, like, the definition, the layers of the scalp, its blood supply, nerve supply, and then, of course, the note on applied anatomy, because you should know where you apply this knowledge, what you have gained clinically. So that is applied anatomy part. So when we say definition, so what do we mean by scalp? So scalp is a connective tissue covering. So where do we see it? Is basically, it is the covering which covers it's a soft tissue covering which covers the calvaria. So calvaria, when we say, that is the skull, covering of the skull. So here you can see, so this is the covering of the skull, and scalp is this, this is the skull, and this is the skin which is covering the scalp. So first you should always focus on the definition. What is it? So the definition here of scalp is, it is a soft tissue which covers the calvaria of the skull, or the skull vault. So now next will be the extent. So from where to where is it covering? Okay. So when we say where to where it is covering, it is like anterior to posterior and on the lateral side, on each side. So when we say the scalp here, it will extend from the supraorbital margin. So in the front, the scalp doesn't have a bony attachment. This is very important point to remember clinically. So it doesn't have a very, any bony attachment in the front. So it becomes continuous with the skin of the forehead here. So it extends from the supraorbital margin in the front here, okay? And it will extend posteriorly up to the external occipital protuberance. And on either side of the external occipital protuberance, there will be the superior nuchal line. So it extends up to there. And on each side, it merges. So here on the sides, it will merge with the temporal fascia. Okay, so it extends up to the zygomatic arch, and there where it will extend that is the temporal fascia. Okay, so the things which you need to know, as I said, first will be the definition. So you should define what is scalp. Okay, so when we say okay, so first is you will write the definition. Okay, so define it. Okay, so in one line, you should define. So what is it? It is a soft tissue covering of the cranial vault. That's it. Okay, then you will write the extent. Okay, so always prefer to write the answers in points rather than in sentences, in paragraphs. So that will avoid, you won't have any lack of time. It will have a better presentation, how you present the answers, as well as you can cover so many things in short period of time. So you will write extent. So what will you write? From anterior to posterior. Okay, anterior to posterior, what is the extent? So supraorbital margin to the posteriorly to the external occipital protuberance. That's all. You don't have to write it extends from so much, from here to here, and using all English and the grammar is not necessary here. Okay, so the words are more than important. So the keywords you should not miss. And on each side, that is each side or laterally, it will extend up to where? Okay, so up to the zygomatic arch where it merges with the temporal fascia. Next is after this, the layers. Okay, next thing is the layers of the scalp. So if you see the scalp, the acronym, scalp itself is an acronym for its layers. Okay, so if you take each part, it is an acronym. So you will write scalp, which are the layers. So first will be the skin. Next will be the connective tissue. Then will be the aponeurosis with the muscles. And then we have the loose areolar tissue layer. And the last layer will be the pericranium. Okay, so these are the layers, that is the 5 layers of the scalp. So each letter of scalp stands as an acronym, like, for the layers. So it is easier to remember. And now when it is a long essay question, you will have to describe each layer. So the key features. Now skin. What is the key feature of the skin? It is a thin skin and it is as abundant hair as well as when there is hair, what will be abundant there? There will be sweat glands, there will be sebaceous glands. Okay, so it has a rich supply of sebaceous glands and it is highly vascular. So these are the 3 things which you need to write. And third thing is, it is adherent. So what does the skin? Skin will be adherent to the underlying layer. So these 3 layers, will be very adherent. In the living also, it will be adherent. So skin will be connected to the lower aponeurotic layer, that is the 3rd layer, through this connective tissue, and it will be adherent. Okay, so this is also an important point, because when we talk about the applied aspects, it is important because when there is a lacerated wound, when there is a cut in the skin, okay, so what happens is it bleeds a lot, though it is a small cut. The same length of cut, the same depth of cut in any other part of the body will bleed less when compared to the scalp. That is because since the skin is adherent to the underlying layer, the skin cannot retract. Okay, the blood vessels cannot retract because it is attached there below. Okay, so that is why it bleeds more. That is why we need to apply pressure and wait till the bleeding time, the normal bleeding time, till then you apply the pressure so that the bleeding stops. Okay, so this is about the skin. Okay, so skin is thin type of skin, has abundant hair and sweat and hair follicles. Sweat as well as sebaceous glands are present, and then it is adherent to the underlying layer. It is highly vascular. So that is why the reason where it bleeds a lot. Next will be the connective tissue layer. So connective tissue layer here has what? It attaches the overlying skin to the underlying aponeurosis. That is its function. That's it. Okay. So then we have the aponeurotic layer. So aponeurosis layer will otherwise called as gallia aponeurotica. So it is also called as gallia aponeurotica. Okay. So what will this layer have? So this layer has the aponeurosis. Okay, as well as 2 muscles, which we call together as occipitofrontalis muscle. Okay, occipitofrontalis muscle. So this is present in the 3rd layer, aponeurosis, and the occipitofrontalis muscle. So in the front of the scalp, that is the anterior part of the scalp, you will see the frontalis muscle, whereas posterior part, you will see the occipitalis muscle. So together we call them as the occipitofrontalis muscle. So the frontalis muscle anteriorly, since I told you the scalp doesn't have any bony attachment. So where does it attaches? It begins from, it's a subcutaneous muscle. Okay, it has origin from the skin there, and then it gets inserted to the aponeurosis in the center. Whereas from posteriorly, the occipitalis muscle. So it begins from the superior nuchal lines. Okay, superior nuchal lines, and then it further. So occipitalis will have bony attachment, begins from this. So that is the extent of the scalp posteriorly. So it begins from there, and then it gets attached to the aponeurosis. That is about the 3rd layer. So you need to mention only these things. Okay. So what we see there. Next, we have the loose areolar tissue layer. So loose areolar tissue layer. Okay, this is a very important layer. The 4th layer of the scalp is very important. Okay, because this layer is otherwise also called as the dangerous layer of the scalp. Okay, so dangerous layer of the scalp. Now, before you talk about the dangerous, why it is dangerous, so you should first say why, what is present there, what is the normal things there. Okay, so here in the loose areolar tissue, so as the name says, it consists of loose areolar tissue. Okay, so because of this loose areolar tissue, there is a potential space now between the overlying 3 layers and underlying pericranium, because I told you the first 3 layers are adherent. Okay, So this is the same. So the loose areolar tissue layer will have the tissue, areolar tissue, and the important content there is the emissary veins. Okay, now what are these emissary veins? Emissary veins connect the intracranial veins with the extracranial veins. Okay, they connect the intracranial. Now, why do they connect? Why do you have to connect the intracranial with the extracranial? To equalize the pressure. So that is the function. So we see an important content, that is the emissary veins there. And okay, if the emissary veins are present, why will it be dangerous then? Okay, so if there is any infection in the loose areolar tissue, okay, or because of trauma or something, and there is an infection in the loose areolar tissue layer, this infection can spread through these emissary veins to the intracranial cavity. Okay, because emissary veins are valveless. So the blood flow is in either direction because it has to equalize the pressure, intracranial and extracranial pressure. We have these emissary veins, right? So what happens is if there is infection through these emissary veins, it can spread through intracranial. That is why it is called as the dangerous layer of the scalp. Okay. And last layer is the pericranium. So this pericranium is the outer covering. So if you see here, that will be the outer covering or pericranium or the periosteum, what we say, it will be the outermost covering of the cranial vault. Okay. In the scalp, it is the most innermost layer, the fifth layer. So it will be covering the, what is that, cranial vault. But here one thing you have to remember, unlike the other layers, which are continuous from anterior to posterior, this layer covers each bone. Now we know that cranial vault has different bones, right? You have the frontal bone, the parietal bones, right? A small portion of temporal bones. Behind we have what is that, occipital bone also. So along these bones, there is the suture lines, that is the joints. Okay, so this pericranium is limited, like, it becomes continuous with the endosteal layer along the suture lines. This is a very important point which you need to write there. This is all you need to write about each layer. Okay, the main key words, key points. Next, we move on to the next question, that is the blood supply of the scalp, where you have to talk. So now blood supply, when we come to of the scalp, see, always remember when we say blood supply, it includes the arterial supply as well as the venous drainage. Okay. And usually when we talk about the scalp blood supply, we usually talk in quadrants. That is the anterior quadrants and posterior quadrants. So what do we mean by that? Anterior quadrant and posterior quadrant. So when we say anterior quadrant, it is the portion. So this is the ears, auricles, right? So the portion of the scalp in front of the auricle is the anterior quadrant and behind the auricle is the posterior quadrant. So we talk about the blood supply accordingly. Okay, anterior quadrant. So in the question, if it is specifically asked like anterior quadrant, you don't have to bother about posterior quadrant. You all write the general features, scalp layers, then you just talk about the anterior quadrant blood supply, anterior quadrant nerve supply. But if it is a general question as just scalp without mentioning any quadrants, anterior or posterior, then you need to, that is about, you have to talk about the entire blood supply, right? Okay. So now here I will talk about like as anterior and posterior and go on. Okay. So in front of the auricle, okay, that is the anterior quadrant of the scalp is supplied by 3 blood vessels. Okay. So we have supratrochlear, supraorbital, and superficial temporal. Now here, okay, so basically the scalp is supplied by the branches of internal carotid and external carotid. Okay, that is a thing you should know. So the branches from the internal carotid include the supratrochlear and the supraorbital. And from the external carotid, we have its terminal branch, that is the superficial temporal. Okay, this is the anterior quadrant. Posterior quadrant, the arterial supply is by the posterior auricular artery and occipital artery, which are both branches from the external carotid. So this is the arterial supply. Now coming to the venous drainage. So venous drainage again from the anterior part and the posterior part, what happens? So when we talk about the anterior part, okay, so this is the anterior quadrant venous drainage, whereas this will be the posterior quadrant venous drainage. So anterior quadrant venous drainage, so when we say, okay, so just like how we have the arteries, the similar named veins are there. Okay, so just like supratrochlear and supraorbital. So here we have the supratrochlear and the supraorbital vein, which will join to form the angular vein. Okay, unlike, see, in arteries, we say branches, but here in veins, we call them as tributaries because smaller veins join together and form a larger vein, bigger vein. Okay, so supratrochlear vein and supraorbital vein, they join to form the angular vein. And angular vein continues, okay, as the facial vein. Okay, it continues as the facial vein. You can see here. Okay, it continues as the facial vein, and facial vein, okay, will join the anterior division of the retromandibular vein to form the common facial vein, and it will drain into the internal jugular vein. So finally, the drainage is into the that is the internal jugular vein. Now, how does this anterior division come? So here we have the superficial temporal vein, which is again draining the anterior quadrant of the scalp, right? So this superficial temporal vein will join the maxillary vein, and it forms the retromandibular vein. Okay, it joins the maxillary vein, forms the retromandibular. This happens within the parotid gland. So when the vein comes out from the parotid gland, it divides into an anterior division and a posterior division. So this anterior division joins this facial vein to form the common facial, and it drains into the internal jugular. Now here, what about the posterior quadrant now? Okay, so posterior quadrant, we have the posterior auricular vein. Similar name vein. We have posterior auricle or occipital artery, right? So similarly, we have this posterior auricular vein. Now this posterior auricular vein is joining the posterior division of retromandibular vein, and it is forming the external jugular vein. Okay, and this external jugular vein will drain into the subclavian, like below. Okay, so this is how posterior quadrant, and we have the most posterior part, that is in the occipital part. It drains in the occipital venous plexus. Okay, so this is the venous drainage of the scalp. So summarize, when we talk about the what is that, blood supply. Okay, so blood supply, you should include both arterial supply, okay, and you have to talk about the venous drainage. Okay, so venous, we don't say venous supply, we say venous drainage, whereas the arteries will supply. Okay, so arterial supply. Okay, so arterial supply is by the branches of external carotid and, okay, external carotid artery and internal carotid artery. So here what do we divide? We divide it into anterior quadrant, which arteries supply, okay, and posterior quadrant, which arteries will supply. So you have to talk about that, okay. And venous drainage also similarly, you will talk about anterior quadrant and posterior quadrant, okay. So anterior quadrant, when we say, it is in the front of the auricle. So you will say that, and you will talk about how the supratrochlear and supraorbital vein, orbital will join to form angular, and angular will continue as facial. Facial will join the facial will join which one? The anterior division of retromandibular, and then it forms the common facial. Common facial will drain into internal jugular vein. Okay, so when you are learning, you can just like this, like, flow diagram, you can write and learn. Even in the exams, you can use the similar things. Okay, when you have to write the answer, it's not like you need to write. Avoid paragraphs. Okay, always tell students to avoid paragraphs, because when the examiner corrects your paper, they are they are likely to miss certain points what you have written. Okay, and it's better. That is why it's better to write in bullet points, the main points, underline the keywords. So that is very essential when you present the answer. So that is all the tricks where you can score better. Then the posterior quadrant, you will write how there is formation of the external jugular vein. Okay, external jugular vein, as well as the occipital plexus, you will write. Okay, so that is in the posterior. So that is about the blood supply. Next is nerve supply, is very important. Now nerve supply. So on each side, okay, on each side of the scalp, okay, about 10 nerves supply. So among these 10 nerves, okay, 8 are sensory and 2 are motor. And among these 10 again, on each side, 5 supply in front of the auricle, that is the anterior quadrant, and 5 supply the posterior quadrant. Okay. Okay. So now this is what you will write beginning. So we have 10 nerves supplying, okay, so supplying each side of the scalp, okay, and in the 10 nerves, there are 2 motor and 8 sensory, okay, 8 are sensory, and anterior quadrant will have 4 sensory and posterior quadrant will have 4 sensory and 1 motor. Similarly, posterior quadrant will also have 4 sensory and 1 motor. Okay. So the sensory branches are coming from where? Sensory branches are coming from the cervical nerves. Okay. C1, C2, and a little bit of C3. Otherwise, mainly C1 and C2 it comes from. And whereas the motor is from the facial nerve. Facial nerve branches supply the motor supply. So motor supply is for what here? Motor is usually for the muscles, isn't it? So motor supply. So anteriorly, why? We have one to supply the frontalis muscle. Posteriorly, we have one to supply the occipitalis muscle. Okay. So which are the? So you will draw a simple diagram like this and you will write these branches. Okay. You just explain like this. You will just write these points. And then you will write supratrochlear, supraorbital. So these are sensory, okay? Supraorbital, supratrochlear, and zygomatico-temporal we have, okay? And auriculotemporal, okay? Zygomatico-temporal and auricular. This 1, 2, 3, 4, all these 4 are sensory, okay? So in between this zygomatico-temporal and auriculotemporal, we will have one more nerve here, which is called as the zygomatic branch. Okay, this will be the zygomatic branch of facial. Okay, so that will be supplying the frontalis. I'm sorry, not zygomatic. I meant to say temporal. Sorry. Okay, so temporal branch of facial nerve. Not the zygomatic branch, temporal branch, not this one, ignore this. So temporal branch of facial nerve will supply the frontalis muscle, okay? So we have 4 sensory there, supratrochlear, supraorbital, zygomatico-temporal, auriculotemporal. So between that zygomatico-temporal and auriculotemporal, we have the temporal branch of facial supplying the frontalis muscle, okay? Behind, we have great auricular, behind the ear, okay, that is the posterior quadrant. We have great auricular, lesser occipital, greater occipital, and third occipital. Okay, greater auricular, lesser occipital, greater occipital, and third occipital. So all these 4 are sensory. Okay, and the motor here is this one. Okay, so the motor here will be the posterior auricular branch. Okay, so the posterior auricular branch of facial will supply the occipitalis muscle. So if you observe here, okay, in front of the ear, there is 1 sensory, 1 motor. Behind the ear, there is 1 sensory. So just in front of the front and behind the ear, so if you get confused where this motor branch is, so you can see here, in front and behind the ear, there are sensory branches. And just in front of that, in the front will be motor branch and just behind that will be the motor branch, okay? So this is the nerve supply. So with the diagram, you will explain about this nerve supply. So I hope it is clear to you. So the nerve supply when we say, okay, so how many nerves? 10 nerves. Okay, so the 10 nerves again, we have 10 on each side. Okay, so among the 10 nerves, anterior quadrant 5, posterior quadrant 5. Okay, anterior quadrant again 5. Among these 5, we have 4 sensory, 1 motor. Okay, and here also similar thing, 4 sensory, 1 motor. Okay, so the sensory is coming from they are the branches of C1, C2, C3. Okay. Whereas the motor, they are the branches of facial nerve. Okay. And you will write about those 4 branches which are there. Okay. 4 sensory in front and 1 motor, and 4 sensory behind and 1 motor. Next, just to know about a little bit more, I already told you why it is the danger. Sometimes just the dangerous layer of the scalp, like, give the anatomical basis, why the 4th layer is, or which is the layer which is called as dangerous, and give the anatomical basis for it is asked. Okay. So you need to answer that question. So that time, what do we write? So first we'll say which layer is, so which layer was the dangerous layer? The 4th layer was dangerous. 4th layer is called as dangerous layer. So why it is called dangerous layer? Because in this layer, what do we see? Okay, we see the, so in the dangerous layer, what do we see? We see the emissary veins. Okay, we see the emissary veins. And emissary veins, what do? They are valveless. Okay, they do not have valves. And they connect the intracranial with the extracranial veins. Intracranial veins to the extracranial veins. So, why do they connect them? What is the necessity to connect? It connects because it has to equalize the pressure on both the sides, isn't it? So that is why it connects. Now, what happens is, so if there is any infection, it can spread to this layer. Okay, it can spread in this layer, okay, through these emissary veins to the intracranial veins. Okay, and it so the extracranial infection can spread intracranially. Okay, next, what do we have to know is, another thing is, I told you it is a loose areolar tissue. There is a space there, okay? In that loose areolar tissue layer, there is a potential space. So why is it important now? Why this potential space is important? So scalp in the front, okay? Anteriorly, it is not attached to any bone, okay? So it becomes continuous with the skin of the forehead. So why this is important? Skin of the forehead, why is it important is, see here, since, what is that? It has no bony attachment. So if there is trauma and there is collection of blood, okay, so which we call it as hematoma. So in this, what is that? 4th layer, it doesn't get restricted to one part. So that blood will spread because there is a space. It will not be collected at one part. Instead, it spreads. And especially since in the front, okay, it has no bony attachment and it extends up to the supraorbital margin and becomes continuous with the skin of the forehead, it will spread to the eye along the periorbital skin, okay, around the eye. So that is why when there is head trauma, head injury and all, there will be orbital swelling, periorbital. Here also you can see, initially you will see, and then it scrolls around the eye. So you can see this is known as the black eye, okay. So that is basically because if there is a trauma there, it spreads. Since it has no bony attachment, it spreads around. So usually, initially it looks just a swelling, but in 2-3 days, because the blood breaks down there, no, it becomes more blackish, okay, and slowly it will resolve, okay. This is one thing you need to keep in mind. So this is about the scalp, which you need to know, the definition, the layers. Okay, so definition, the extent, then the layers, then each point about each layer, then finally the blood supply, the nerve supply, and the applied aspects. So applied aspects you talk about. So here you talk about in the applied aspects, you should mention applied aspects writing is very important. So first, so you go by layer. Okay, so first is skin. Now, anyway, skin is adherent to the under 3 layers down, no? All the 3 layers are adherent. Okay, so what will you see? I told you skin is very highly vascular. So because of that, if there is any laceration, it will bleed profusely. Okay, so lacerated wounds will bleed, cause profuse bleeding. Okay, that is one thing. Okay, so that is the thing. And also, if the skin of the scalp, since has a very rich blood supply, if the whole scalp skin comes out also, it can be resutured. Okay, it can easily be, it will easily accept and it will heal fast. Second thing is, in the skin, I said there is rich supply of sebaceous glands. Wherever there is hair follicles, there will be sebaceous glands. So these sebaceous glands can cause boils, okay, which will cause boils, are very common in the scalp. And this boil, since the skin is adherent to the underlying layer, these boils become very painful in the scalp. Some of you might have experienced it also, right? And this sebaceous glands can also cause cysts, sebaceous cysts. Okay, so these are the two things which are common there again. And third thing which you have to know here is about the dangerous layer of the scalp. So you should talk about the dangerous layer of the scalp. Then you should talk about the black eye. Okay, so these are the things which you need to focus on when you talk about the blood supply. Okay. Right. So next we go on to the next question, that is the nerve supply of the face. Now, this is very important question. Now again, face. Okay, so face, it involves the entire muscles there, okay, and the skin covering that. So we need to know both the motor as well as the sensory supply and the applied aspects there, okay. So nerve supply of the face, when we say, excuse me, so first we talk about the motor supply, so which nerve supplies the muscles there, and which nerve supplies the skin there. And what if the nerve is injured or there is any lesion which causes injury of the nerve, what will happen? Okay, these are the things which you need to focus on. So first is the motor supply. Okay, so motor supply of the face, when we talk about, okay, so it is basically by the facial nerve. So facial nerve is the main nerve which supplies the what is that? Face, okay, the muscles of the face. Okay, so when you're writing about the facial nerve, when you're describing this, see, writing about a nerve is a different way of writing the answer. But when you're talking about the nerve supply to the face, you have to focus on just a few points and know what exactly to write. So what are the things you will write? Okay, so you will write facial nerve. Okay, so what you will write is, so facial nerve will give what supply? Will give motor supply, right? So it gives the motor supply. So next what? After that, it's a motor supply and supplies the facial muscles on each side. So there are two facial nerves, right? Right and left. So where it begins? Begins in the sense in the face, where will it appear? Okay, so that origin in the, okay. Then how it will, the branches, okay, which supplies the face. Then you will write about it as applied part. Okay. So now when you see in the face, for the face, applying the face, the facial nerve is emerging from the stylomastoid foramen. Okay. So if you see here, okay, so it is emerging from the stylomastoid foramen. And where is the stylomastoid foramen? Between the styloid process and the mastoid process. So after emerging from here, so we are just talking about here, okay? We are not as such concentrating on the facial nerve nuclei, where it is and how it is, what about its intracranial course, nothing. We are just concentrating on the extracranial course of the facial nerve and how it is giving the branches. Okay, so it comes out from the cranial cavity through the stylomastoid foramen. Okay, it pierces the posterior border of the parotid gland. Okay, so through the posterior border, it enters the parotid gland. So it passes through the substance of the parotid gland. So within the substance, it will give two branches. Okay, it will divide into temporofacial and cervicofacial branch. Okay, temporofacial and cervicofacial branch. So the temporofacial branch, what will it give? It will again divide into, so just along the anterior border of the parotid gland, it will emerge out by giving branches. So which branches will it give? Okay, so it gives temporal branch and zygomatic branch. Okay, so this, the way the facial nerve branches emerge outside, no, it looks like the feet of the duck. Okay, that is why it is called as pes anserinus, like the 5 digits, no, it comes out like that, like a webbed feet, it comes out and it gives the supply. So first here will be the temporal branch. Okay, so the temporal branch will be supplying all this frontalis muscle, the corrugator supercilii muscle, the orbicularis, okay, the upper part here it supplies. The second branch will be the temporal branch. Okay, temporal lobe, the zygomatic branch. Okay, so zygomatic branch will also be given here from the temporofacial branch. Okay, after that, from the cervicofacial, it gives 3 branches. Okay, so that is the upper buccal, the lower buccal, and the cervical. Okay, cervical and marginal mandibular. This is the marginal mandibular. So you can see here 1, 2, 3, 4 branches given by the cervicofacial. Okay, so upper buccal, lower buccal, marginal mandibular, and cervical. So upper buccal will supply the muscles that is on the upper cheek part, okay, and the upper lip part here. Whereas the lower buccal will supply the lower part of the cheek muscles. Then the marginal mandibular, so it will supply the muscles along the mandible. Okay, and cervical will supply the platysma. So this is about the facial nerve branches. Okay, so this is motor supply. This is all you need to know, which area it is supplying, what muscles. So how you write the answer? Okay, so how you write the answer here for better. Each muscle, each branch, you can't write like, this temporal branch will supply so and so, temporal, zygomatic. You don't have to go like that. What instead of that, after you write where it is coming and passing through its course, after you mention the origin and course, the next thing when you write will be about the, you will write where it originated, the course in the parotid, just in briefly. You don't have to explain the whole thing, and how it gave the branches. So next what you can write is, when you write about the area of supply, you can just make 2 columns. Okay, here you can write the branch, here you can write the muscle supply. Okay, so this will give a better presentation. So first branch will be temporal. So you will write, at least if you can't remember all the muscles, when you know that picture, the picture is in your mind, you need to practice drawing the diagrams and saying, okay, you don't have to, when you draw the diagram also, you don't have to show all these muscles if it is difficult for you. Okay, you don't have to even draw the face part also. You can just show a little bit of these 2 things, which is coming out and giving the branches. Okay, instead of the facial margin here, you can just show the muscles what it is supplying. Okay, so you will write temporal, you will mention the muscle like frontalis, corrugator supercilii, then zygomatic branch, which muscle it supplies. Okay, so like that, upper buccal, lower buccal. So this gives a better presentation, and even scoring wise, we score better. Always remember, it is not the quantity of the answer, it is the quality of the answer which matters. Not the quantity, but the quality. So how you present the answer, how briefly you present the answer, how well you present the answer, including whatever the examiner is looking for in the question, and in that answer for that question is what you need to understand and write. That is what we call by smart answering. Okay, so most of you will have a tremendous knowledge. Okay, you will remember a lot of anatomy, and you will be confused as what to write. So once you understand the concepts, always focus on how to present the answer and how to write the answers better. Okay, next, when you write about the applied aspects here, in facial nerve injury or facial nerve lesion, the condition which results there is the Bell's palsy. Okay, so here facial nerve lesion, we have 2 kinds. Okay, one is supranuclear and one is infranuclear lesion. So what do we mean by supranuclear and infranuclear lesion? So all of you know, this is just for you to understand, I'm saying. Okay, supranuclear, we call it as upper motor neuron lesion, and infranuclear is lower motor neuron lesion. Okay, now the facial nucleus. So where is the facial nerve nucleus? Facial nerve nucleus is situated, okay, at the pontomedullary junction. Okay, at the pontomedullary junction it is present. So this nucleus, what happens is, above that, whatever the fibers, now see, it is the motor supply. So where should the fibers coming from? Highest center for motor is in the cerebral cortex, isn't it? So it is coming from the frontal lobe. That is basically by the motor area. Okay, area number 4, that is in the cortex, it is coming. Okay, through the pyramidal tract. It will come. Okay, so these motor fibers, what happens is they go to the nuclei. Okay, so they go to the facial nucleus. So if you see here, well, if this is the right side and this is the left side, most of the fibers are crossing over. So you know that pyramidal tract crosses over, right? only few of the fibers go to the same side. So this point is very important when we know about the clinical signs and symptoms. Okay. So these fibers which cross over, so from the facial nerve nucleus, the facial nerve will begin and it will supply the same side. So what happens is now if you see here, okay, so from the right side, most of the fibers have gone to the left side, okay, and okay, sorry, from the here in the face, if you see, this is the left. So from the left side, it is gone to the right side facial nucleus, and from the right side, the right facial nerve is supplying the right half of the face. So basically, where were these fibers which are supplying here originating? In the left side. So similarly to the right half of the face, I mean left half of the face, it is coming from the right side and going to the left. Okay. So when we say supranuclear lesion means upper motor neuron lesion means the lesion is up here where the fibers begin from the cortex, cerebral cortex. Okay. So when these fibers, there is an injury here, it results in the upper motor neuron lesion. Okay. So now, for example, now here what has happened? This fibers which are coming from the left side, they have a lesion, some tumor, some growth is there, or this nerve is injured here. Okay. So these fibers are affected, correct? So when these fibers are affected, what will happen? The right half of the face, okay, should be affected, isn't it? Because it is supplying the right half of the face. It has crossed over, gone to the right nucleus and supplying the right half of the face. Okay. Right. So here when it is supplying, if you see what happens here, they are showing the lesion only in the lower half, but they are not showing the lesion in the upper half. Why shouldn't the upper half be affected? What happens here? Okay. So upper half is not affected here because, so if you carefully see, some fibers are coming straight like this, means the right side fibers are not crossing to the left side, instead they are coming straight, okay, and they will come to the same side. Now this right side, was it affected? It was not affected, right? Right side is not affected. So what is happening is, this upper part of the face and these right fibers which come now, they supply, that is from the same side, they supply only the upper half of the face. They don't supply the lower half of the face. So what we say is, the upper half of the face has got bilateral representation, means upper half of the face is supplied both by the right side as well as the left side fibers. Okay. So from both the side fibers, it is supplied. Okay. Are you getting it? So here, so that is why upper half of the face is spared in case of upper motor neuron lesion. Whereas in lower motor neuron lesion means after the nerve emerges from the nucleus. Okay, that is the infranuclear lesion. So here it is the entire nerve which is affected. Okay, the facial nerve which is supplying the same side. So here what happens is, the entire half of the face is affected. Okay, here the entire half, because here, now here why the upper? Because you may say upper half is represented, why not the upper half is paid? Okay, but here what happens? The upper half which is coming from the same side also, they have also joined which fibers? The facial nerve to supply. Okay, so because of which, so those fibers are also affected here because the facial nerve is affected here, not up here. Here it was affected up here. So these fibers of the same side, they remain unaffected except for the fibers which were coming from the other side were affected. But here, since it is below, both the fibers which are coming from the same side as well as from the opposite side are affected. Okay, so this is Bell's palsy. Okay, so you have to represent drawing a diagram showing like this, okay, where it is affected and what will be the signs and symptoms. Okay, are you clear with that? So when we see here, if it is what is that, lower motor neuron lesion, so you will have loss of wrinkles, okay, because the upper muscles, all that frontalis and all, they are responsible for the wrinkling, then inability to close the eye. So there is continuous tearing epiphora, we say. Then there is loss of the nasolabial fold, drooling of the saliva, the mouth is directed, deviated to the opposite side, okay, where it is normal. Okay, whereas if it is a upper motor neuron lesion, then the upper half of the face remains Okay, it will remain normal. Upper half of the face, only the lower half will be affected. Okay, so that is the thing. Next, you have to know the sensory supply of the face. Now, sensory supply of the face, when we say, it is by the divisions of trigeminal nerve and their branches. Okay, so which is the trigeminal nerve now? Trigeminal nerve is again a cranial nerve, right? So fifth cranial nerve. So this trigeminal nerve will give three divisions: ophthalmic division, maxillary division, and mandibular division. So these divisions supply the skin of the face, skin over the face. Here, one thing you have to remember is just the angle of the face. Okay, this is near the angle of the mandible here. This portion is supplied by one more different nerve, that is the great auricular. Okay, so great auricular nerve that supplies the okay, so on the angle. So this is one thing. So even the trigeminal nerve is affected, this area is spared. That is because it is supplied by the great auricular nerve. Okay, so you can see here. So now coming to the divisions. Okay, so after that, when you write about the three divisions, each division, what branches it is giving. Okay, so the first division is the ophthalmic, right? So ophthalmic is giving 5 branches. So if you see here, supratrochlear, supraorbital branches, then we have the supratrochlear, infratrochlear. You can pair it and remember supratrochlear and infratrochlear. Below that will be the external nasal. Okay. Then here we have supraorbital and lacrimal. So these branches are given by the ophthalmic division. Then we have the maxillary division. Maxillary division gives infraorbital, zygomaticofacial, and zygomaticotemporal. So going towards from this is the zygomatic bone. So from this going upwards is zygomaticotemporal, coming downwards will be the zygomaticofacial and infraorbital. That is from the infraorbital foramen it comes. Then we have the mandibular division. Mandibular division will give buccal, mental, okay, and it will also give this auriculotemporal nerve. Okay, and we have the angle here supplied by the great auricular nerve. Okay, so if we take into consideration the nerve supply of the face on each side is by, okay, so nerve supply of the face on each side, okay, is by 13 nerves. Out of that 13 nerve, one is motor, which is facial. Okay, then we have 12 sensory. Okay, and out of these 12 sensory, one is by the great auricular nerve. Okay, and rest 11 are by the branches of, are by the trigeminal. Okay, by the divisions of trigeminal. So trigeminal here will give ophthalmic, maxillary, and mandibular. Ophthalmic, maxillary, and mandibular. Okay, so ophthalmic, when we say, it gives 5 branches here, then it gives this one, which is that maxillary will give 3, mandibular will give 3. Okay, so altogether 11. So this is the nerve supply of the face. Okay, so this is what you need to understand. So if nerve supply of face is asked, you have to talk about both motor supply, which is by the facial, sensory supply by the trigeminal, and applied aspect talking about the, if it is sensory loss, then there will be loss of sensations over the skin. The pressure, touch, temperature, sensations, general sensations of the skin is lost. If it is, sorry, if it is motor loss, it is about the palsy, Bell's palsy you need to talk about. Okay, then is the lacrimal apparatus. So when we talk about the lacrimal apparatus now, okay, so lacrimal apparatus here, basically this is asked as like, you know, a short question. So short question on yes, you have to talk about first, what is this lacrimal apparatus? Okay, what do we mean by lacrimal apparatus? So basically lacrimal apparatus includes the gland and the pathway for the formation of the lacrimal secretions, that is the tears, and for its excretion, that is for its passage. Okay. Yes. So what do they include? So first, there should be a gland, isn't it? To secrete something, there should be a gland. So glands are what? Secrete. So a gland, so that is the lacrimal gland. So lacrimal gland, then the lacrimal ducts. Okay, so lacrimal gland will have two parts, the palpebral and the orbital part will have. Okay, so the ducts are connected there and they form the excretory lacrimal duct. Okay, then it goes into the, we have the next part there will be the conjunctival sac. Okay, so it goes to that and then it finally gets to the lacrimal sac. So conjunctiva, okay, then to the lacrimal sac here. So from the lacrimal sac, okay, here you can see better, okay. So we have the glands here, so you see this, okay. So these are the lacrimal ducts here. So lacrimal ducts, you can draw a simple diagram like this, okay. So this is the orbital as well as this is the palpebral part, okay, of the lacrimal gland, two parts which are separated by this levator palpebrae superioris muscle. So the ducts of this orbital will traverse through the palpebral part and it opens into this, what is that, conjunctival sac. So from the conjunctival sac, the tears go here to the lacrimal punctum. Okay, there is a punctum. You may have noticed it at the medial angle of the eye. Let's know, you can see that. And this lacrimal punctum leads to the lacrimal canaliculus here. Okay, and then the lacrimal sac, and lacrimal sac, okay, it leads to this nasolacrimal duct, which opens in the inferior meatus of the nose. Okay, so these forms part of the apparatus, lacrimal apparatus. So with a simple diagram, you can name the components. So whenever the question is name the components, you just have to, especially this question is asked as draw the lacrimal apparatus and describe its components or name the components. So these are the, usually it is to name the components. So you have to start from the first, like, you know, first the lacrimal gland. So lacrimal glands leads to lacrimal ducts. From lacrimal ducts, the conjunctival sac to the punctum. Okay, so from the punctum to the canaliculus, and from the canaliculus to the lacrimal sac. Okay, and lacrimal sac to nasolacrimal duct. Okay, so it goes that way and opens into the, and this nasolacrimal duct will open into the inferior meatus of the nose. Okay, so you just have to, in an order of the pathway of this passage of lacrimal secretions, you need to mention it. Okay. Then coming to the short answers. So short answers here, we will be knowing about the muscles. So some of the important muscles of the face are asked. So one is the orbicularis oculi muscle. Okay. So this orbicularis oculi muscle is very important muscle. Okay. So basically, if you see here, it is surrounding the eye. Okay. It surrounds all around the eye. So that is why orbicularis, it is orbiting around the eye. That is why that orbicularis and oculi means eye. Okay, so that is the name. So now here, whenever you describe a muscle, these headings should be there. One is the origin, second is the insertion, third nerve supply, and fourth is the action. Okay, so what is the origin? What do we mean by the origin of the muscle? So how do you write the answer? When you write about the origin, you write where it is originating from. Okay, in the textbooks, since it for the completion's sake, they give a lot of explanation for you to understand how, from where, and many side, and all those things they give. You don't have to worry about if you can't remember those things, but the key points, where exactly it is coming from, you need to know. Okay, if it is a single muscle, okay, from which point it is coming. Sometimes like this orbicularis muscle, it has three parts. Okay, it has the orbital part, it has the palpebral part, and there is the lacrimal part. So it has got three parts. So you need to mention that first. Okay, orbicularis muscle, oriculi, has three parts, the orbital, the palpebral, and the lacrimal. That is the first thing you need to write. After that, you write about the origin. So origin, where you, what you can do is, when you write the origin and insertion, okay, you can always, like, you know, you can make the column. Okay. Okay, I'll put it here itself. Huh? So the part, okay, then you write about the origin, and then you write about the insertion. So this is a better way. This will avoid writing sentences. You know, you don't have to write the sentences. So first part is the orbital part. Okay, orbital part. So orbital part, from where it is coming? So it comes from the medial palpebral ligament. Okay, so you can see here. Medial palpebral. So this is the medial palpebral ligament. So origin is from the medial palpebral ligament. Okay, so it goes, upper fibers go here, lower fibers come this way. Okay, so you just have to know that it comes from the medial palpebral ligament. Okay, so where is it going and inserting? So here what you have to know is this muscle as such is not getting inserted into any bony point, but instead what happens is it gets the upper fibers, no? They blend with the frontalis. What's happening here? So they blend with the frontalis muscle. Okay, so they blend with the frontalis and corrugator supercilii because these muscles are here. Okay, and the next part will be the palpebral part. Okay, so the palpebral part where it is coming from. Okay, so the palpebral part here, as the name says, so this is only small portion here, the fibers. So these upper fibers will blend with this frontalis and the corrugator supercilii. Frontalis will be here, corrugator supercilii is here. The lower fibers will blend with this palpebral part here. Okay, so now here the palpebral part, it lies within the eyelids. Okay, so here we have our eyelids, no? So it is present within the eyelids. That is why it is called as the palpebral, because we can blink the eyes, right? We can close the palpebral part, it is. Right, so it is coming again. So this palpebral part is also coming from the medial palpebral ligament. Okay, it comes from the medial palpebral ligament, and where it is getting inserted. Okay, it gets inserted into the lateral palpebral raphe. So this is the insertion point. Okay, so this will be the origin point, and it gets inserted into the lateral palpebral raphe. Understand? So these fibers intermingle with that. So finally it comes from this and gets inserted here. Okay, so after the origin insertion, next will be the nerve supply. So nerve supply, you very well know, the upper fibers are supplied by the temporal branch, whereas the lower fibers are supplied by the zygomatic branch, okay, of the facial nerve. So what about the actions? So next you have to write about the actions, okay? So when you write about the actions, again, since this has 3 parts, the actions also will differ, 3 parts, okay? So orbicularis oculis, as such, the entire muscle, okay, entire muscle acts as a sphincter, okay? So it acts as a sphincter of the eyelids, means it closes the eyelids, right? Why will it act like a sphincter? It helps in closing the eyelids as well as especially protecting against dust, protecting against lights, you know, all that intense light, it protects us. Immediately our eyes close, isn't it? Yes, to avoid any injury or anything. Next is you will talk about the palpebral part. Now, palpebral part as such, what will action will it have? Okay, so this palpebral part, it helps in gently closing the eyes, especially when we sleep. Okay, and it is also responsible for voluntary blinking. When we voluntarily blink our eyes involuntary or subconsciously will be blinking, but voluntary when we blink, we use this palpebral part. The third part is the lacrimal part. Okay, so the lacrimal part will help in, what it will do is, the lacrimal part is present. Yeah, I think I forgot to mention, sorry. The lacrimal part origin here. Okay, so the lacrimal part, it lies behind this. Here it will lie. Okay, that is at this point. Okay, where the lacrimal sac is located, right? So it lies just behind that lacrimal sac. So it arises from the crest of the lacrimal bone. Okay, it arises from the crest of the lacrimal bone. And from the lacrimal fascia also it arises. So that is this origin, okay? And it gets inserted into the lateral palpebral. So insertion is finally into the lateral palpebral ligament itself, or the lateral palpebral raphe. Okay, you can also say that. lateral palpebral rapid gets inserted. Okay, so what does this do? So when this muscle, okay, it dilates. So when it contracts, no, it dilates the lacrimal sac, okay, because it is getting inserted on the other side. So when it is getting inserted, so it begins here and getting inserted here. When it is contracting, it will pull. So that time what happens? The lacrimal sac will dilate. Okay, so that will help in easy transport of the lacrimal fluid. Okay, so whenever there is paralysis of this muscle is basically due to injury of the facial nerve, okay, or the branches of the facial nerve which are supplying here. So what will happen? There is drooping of the lower eyelid. Okay, so applied aspect when you write, you will mention two conditions. Okay, so because of the paralysis, it will result in drooping of the eyelid. Okay, drooping, sorry, double O, drooping of the drooping. Okay, and this drooping is otherwise called as ectropion. Okay, ectropion. If you can't remember the name, if you write drooping is also fine at this level. Okay, and next is it will cause continuous tear, that is known as epiphora. So continuous, the tears are spilled. Okay, epiphora. Okay, so it results in ectropion and epiphora. Next muscle is orbicularis oris. Okay, second muscle we'll talk about is orbicularis oris. So again, same way, you need to go about the origin, insertion, nerve supply, and action. Okay, so this is a muscle which is present. So first, we will say where it is present. Orbicularis oris. It is present around the oral opening or the oral fissure, isn't it? So here it will consist of the extrinsic. So this muscle has two parts. Orbicularis oris. Okay, so this oris muscle has two parts, extrinsic part and an intrinsic part. Okay, intrinsic part. Now this extrinsic part, basically it is derived, it is coming from outside. So outside means, extrinsic means outside, right? So extrinsic, it is derived from other facial muscles. So which facial muscles it is? All the muscles which are present around that region, no, it is derived from that. Okay, and it is arranged in three layers. Okay, three strata we say. So it will be the deep strata, deep stratum, okay, intermediate, and we have the superficial. So the deep stratum muscles, okay, the deepest stratum is formed by the incisivus muscles, that is incisivus superior and incisivus inferior. Okay, so what do we mean by that? Incisivus is, see here, this is the maxilla, so this will have an incisive fossa here, okay, from the maxilla. So incisivus superior comes from here and incisivus inferior will come from the mandible. So there will be an incisive fossa. Wherever these incisor teeth are there, just above that in the maxilla, for the upper jaw, and for the lower jaw from the mandible we have that incisive fossa. Okay, so it has the origin from there. And the intermediate, okay, the intermediate stratum is derived from the buccinator muscle. So you see the buccinator muscle here on the side. So from this comes the intermediate fibers. So here what happens is the upper fibers will go to the upper lip and the lower fibers will come to the lower lip. And the superficial stratum is mainly formed by the levator and levator anguli oris, that is from the upper part, which elevate the lip here, and depressor anguli oris. Okay, so these two muscles it will form. Right. So along with these muscles, the other muscles like levator, that is for the lip, which are inserted around the lip, that is levator labii superioris, depressor labii superioris, zygomaticus major, zygomaticus minor. So these also will contribute a little bit, but mainly it is these muscles which form. And when we say intrinsic part is basically consists of the oblique fibers. Okay, so they are extending. See, all these muscles of the face, they are subcutaneous muscle. Okay, we have the skin, we have the superficial, we don't have the deep fascia there. And from the skin, these muscles originate from, right? And or they get inserted to the skin, originate from the bony part, get inserted to the skin part, right? So this intrinsic part of the orbicularis oris, it consists of these oblique fibers and they extend from the skin to the mucous membrane. Okay, so they are just present in that region itself. Okay, it is just restricted to the portion around the oral fissure. So that is why they are called as intrinsic muscles. So they are small fibers, oblique fibers extending from the, that is the skin to the lip. Right. So these are the things which you need to write. Okay. So this is how the fibers are decussating. You can say, so buccinator, the upper fibers will go along the lower lip, upper and lower fibers will go along the upper lip. So here, this point where all these muscles are meeting, this point we call it as the modulus. Okay. So modulus is called. So these muscles, both this orbicularis oculi and orbicularis oris, I told you, they act like sphincters, okay, of the orbicularis oculi of the palpebral fissure, whereas orbicularis oris of the oral fissure. One thing you need to know. Next muscle is the buccinator muscle. So buccinator muscle is the muscle of the cheek, okay. It is the muscle of the cheek, if you see here, okay. So again, so you will write what is buccinator. It's a muscle. It is the facial muscle. It is the muscle of the cheek. Okay, so topographically, it belongs to the cheek. So it has the origin. So when we write about the origin is from where? Okay, so it is coming from, if you see here, it is coming from the alveolar process of the maxilla. Okay, so it originates from alveolar process of the maxilla. Then if you see, it is also coming from the pterygomandibular raphe. Okay. Pterygomandibular raphe, you will see on the inner aspect here exactly. You will not, in the diagram, you're not able to see in the figure. But it comes that pterygomandibular raphe is attached inside, to that lingual of the mandible. So, from there, the fibers will originate, okay, pterygomandibular raphe. And also it extends, it has the origin from a fibrous band. So if you see here from the pterygoid hamulus to the maxillary tuberosity, that is pterygoid hamulus of the pterygoid bone. Okay, we have the medial plate of the pterygoid bone, the medial plate. From there, that pterygoid hamulus is there. From there to the tuberosity, that is behind here. Okay, behind we will have. So from there it originates. Okay, so all these fibers, when they reach the angle of the mouth, okay, so what happens is the upper fibers and the lower fibers, they will decussate. Okay, so upper fibers go to the upper lip, lower fibers go to the upper lip and upper fibers come to the lower lip. So this is how it gets inserted around the mouth. Okay, so here another thing, important point you have to mention some specialties in case if some muscle has some kinds of special features or some structures passing through that, you need to mention, especially when it is asked as a short answer question. Okay, so here three structures will pierce. One is the parotid duct. All of you know that, right? It passes through that, right, before it opens. And second is the buccal branch of mandibular nerve. Buccal branch of mandibular nerve. Okay, buccal branch of mandibular nerve is a different nerve. And 4 or 5 molar, this mucous glands. Okay, the mucous glands now. So they will also pierce through this buccinator. So you can write that at least parotid duct and buccal branch of mandibular nerve. You need to remember. Okay, so what is the action? So action is, so when we come to the action of the muscle, so your action when we talk about, okay, what will it do? It will help in, it will flatten the cheek. Okay, flatten the cheek. Okay, flatten. How does it flatten the cheek? So why it has to flatten the cheek? Sorry. Okay, flatten the cheek against the gums and teeth. So when will it do that? Especially during the acts of mastication, when we chew the food. Okay, so when we chew the food, it will flatten the cheek against the gums and teeth so as to prevent the accumulation of the food in the vestibule of the mouth, that is between the oral, that is mucosa and the gums. Okay, so it prevents the accumulation of food there. then it will help in forcibly expelling the air between the lips. Okay. So when we blow, especially all these wind instruments, when they blow the trumpet and all, no, we use the buccinator more. Okay. So that is what you need to write. Next question is venous drainage. So venous drainage of the face here, we talk about the superficial, the deep veins, the tributaries, and the communications. Okay. So here when we talk, the venous drainage will be similar to that of the, what is that, scalp. Okay. So it is basically by the facial vein. So facial vein, there is the superficial vein, that is the facial vein as such, which is superficial. And there is the deep facial vein. Okay. So so deep facial vein and superficial facial vein. So first, about the facial vein, we will write about the similar thing, that there is supratrochlear vein and supraorbital vein. They join to form the angular vein, and angular vein, okay, continues as the facial vein. Okay, and facial vein joins the anterior division to form the common facial and drains into the internal jugular. Now, these will be the tributaries. Now, which are the tributaries now? The formative veins, okay? That is the supratrochlear, supraorbital, and angular vein. They are the tributaries. Then we have the external nasal vein here. Then we have the superior labial, inferior labial vein. They are the tributaries of this facial vein, okay? So, they are all coming, draining that area of the face and draining finally into the facial vein. And here we have the deep vein, which also joins this, okay, superficial vein before it drains. What is important here is, if you can see all these facial veins, no, unlike the veins in other parts of our body, facial veins do not have valves because they are draining in towards gravity, right? Other veins are draining against the gravity. So to prevent the backflow, okay, and to help drain better, we have the valves in the lower limb veins and the upper limb veins and all those things, whichever has to flow, blood, wherever the vein, in the veins, no, the blood has to flow against the gravity. But here it is not so. The deep vein, okay, it is connected to the, what is that, to the pterygoid venous plexus. So since there is no valve, what happens is, here there can be a backflow, okay, to the pterygoid venous plexus and from there to the cavernous sinus. So this is an important applied aspect you should know. Okay, so deep vein will drain the deeper part of the face region. Okay, but the thing is, it also establishes a communication through the pterygoid venous plexus to the emissary vein. So in case if there is any infection, especially in the dangerous area of the face, that is near the philtrum, okay, where commonly we pick, or children will be scratching there and picking the nose, no? So infections can spread through these veins into the deep vein, and from deep vein there can be infection to the cavernous sinus. Okay, so that is the thing. Then sensory innervation phase, already I have discussed it. So the trigeminal nerve, okay, it is the sensory. So the three divisions of thalamic, maxillary, and the mandibular, supplying here. It is maxillary, it is not maxillary here, mandibular. Okay, so those divisions, and also you should not forget to mention that near the angle of the mandible, it is supplied by the great auricular nerve. Okay, and you mentioned about the branches, that is supraorbital, supratrochlear, the lacrimal, the external nasal, okay, and the infratrochlear branch from the ophthalmic, then the infraorbital, the zygomaticofacial, zygomaticotemporal from the maxillary, and mental, buccal, and the auriculotemporal from the mandible. Okay, so these are the things you have to mention for the sensory nerve supply and angle of this. So when the trigeminal nerve, we should by trigeminal neuralgia, and also there will be pain along the sensory distribution of this nerve, but the angle of the mandible will be spared. That is because of the nerve supply by the great auricular nerve. Okay, so that is one thing we need to keep in mind. I think with that, I conclude today's session. Okay, so I'll see you next in the next session. So thanks for watching. You can actually download those who have not yet, you can download the app. You can get it on Google Play and App Store. And also we have the social media handles where you can access, like, through Instagram, YouTube, and Facebook, as well as Telegram. Okay, and thank you.